Welcome to the Business of Pharmacy podcast, where we explore the business of pharmacy through candid, in-depth conversations with the industry's top leaders. Every Monday, tune in for insights and stories you won't find anywhere else. I'm your host, Mike Kelzer. Greg, introduce yourself to our listeners.
Greg Reybold, General Counsel and Vice President of Healthcare Policy for American Pharmacy Cooperative, or APCI.
Greg, I don't usually start off one of these conversations with one word, but here it goes. Ready?
Ready.
Well,
look, it has been a busy time. It has been an exciting time in a lot of ways. For, I would say, the last year and a half, we've seen a proliferation of PBM and drug pricing bills at the federal level like we've really never seen before. That's a credit to years of work and years of pharmacists advocating for fly-ins and educating their congresspeople. So in a way, it's sort of this really exciting time because, hey, a lot of attention on the issue, a lot of legislation, and I think folks feel good about that. But when you drill down into the details, from a community pharmacy perspective, an independent pharmacy perspective, and this is so important because independent pharmacy was like the OG in sounding the alarm for PBM abuses and PBM practices. Independent pharmacists saw it. They were the first to see it, identify the problems as to patients, as to payers, as to their business models as well. And they were the ones to sound those alarms. And if you look at the overwhelming majority of the legislation that's out there, it doesn't do a whole lot to really address the roots of the problem. And so while it's an exciting time, it's been a really frustrating time as well. And then you add on to the fact that the pharmacists that are in their pharmacy caring for their patients, working long days with their heads down, boy, it's been a tough year, right? I mean, it's been a tough several years. And so we were thrilled to see the introduction of Pharmacists Fight Back Act, HR 9096 by Congressman Auchincloss and Congresswoman Harshbarger. We think it is far and away the most comprehensive piece of legislation to actually address the problems themselves and get to the root of those problems.
As pharmacy owners, I think we're smart enough to know that when you see a lot of stuff happening, I think we've learned enough not to get excited. I've had too many times where you're excited and then like the next day it's like they act like they've never talked to you before. The PBM mafia got to them. Or else in Michigan, we had this bill. You read the first draft and then the next draft comes out. And it's like, was this the same page? But then you get excited. You see the Congress and you see Washington and you're actually in the House of Representatives, the meetings and stuff. It's a lot of excitement, but it hasn't intertwined yet with who needs it.
Yeah, it hasn't, right? I mean, there are some legislation out there that I think in certain ways is very good, right? Lower cost, more transparency, which passed out of the House, has meaningful Medicaid managed care reforms that were espoused by pharmacist and Congressman Buddy Carter, right? So there's provisions in lower cost, more transparency that we like a lot. There's some interesting things that Senate Finance has done that we're certainly supportive of. But in terms of keeping doors open and reining in the most abusive PBM practices, there's very little that does it, right? And so, look, we're on the back end of a biennial, right? The legislative session is coming to a close December 31st, right? But every now and then the stars seem to align at least a little bit. And so you had a blockbuster, and I may get the order of this wrong, but you had, I think, a blockbuster Wall Street Journal article that really highlighted some of the findings of the most recent 3-Axis report. Eye-opening, stunning stuff, right? Which just really got a lot of attention. And obviously, Wall Street Journal, kind of a conservative-leaning paper. Very shortly after that, what you have is the New York Times comes out with a powerful article. And then you get the FTC interim report, which...
Perfect storm in a good way.
Right, perfect storm. And longtime community pharmacy supporter and advocate and champion for PBM reform, Comer, has the oversight hearing. And Pharmacists Fight Back Act gets introduced that day. Congressman Auchincloss really has an opportunity to dress down one of the PBM execs and kind of hit him in the face with their own data. And we're off to the races, right? And all of a sudden, pharmacists have the most comprehensive piece of PBM reform legislation that's ever been introduced at the federal level, far and away the most comprehensive PBM reform legislation. For years, in various circles, there was sort of this feeling that reimbursement is a dirty word, right? It's not okay to talk about the business of pharmacy. It's okay to talk about patients. It's okay to talk about access. It's okay to talk about steering, but reimbursement is somehow a dirty word.
My podcast is underground.
Yeah.
We're on the dark web to
That's
talk
right.
about this stuff.
And you know what, Mike? You're one of the few that's willing to go out there and actually have these hard conversations, because they're not easy conversations. Most pharmacists got into the business because they want to care for people. And it's not comfortable to always have reimbursement talks. But the reality is, if we don't fix the reimbursement model, they're not going to be around to care for people, right? I mean, I feel like at least that's the trajectory. I don't want to be too bombastic. But that's what it feels like. And what I think this legislation has proven, and I hope it's shifting the landscape, because it's proof of concept. The bill's been introduced in July, and here we are in September, so a little over a month. It's got about 14, 15 co-sponsors. Chairman of Oversight, Comer's a co-sponsor. There is an appetite to substantively reform problematic PBM practices in a meaningful way, and also to address reimbursement problems for independent pharmacy, as well as patient-facing abuses as well.
This summer, we rented a cottage up in Empire, Michigan. It's kind of by Traverse City, a few hours from Grand Rapids. And they have all these old books on the shelf, on these old rentals. There's games of Parcheesi and cribbage boards and things like that.
Yahtzee.
Yes. And there was they had all these old books there. And my son, who's an English grad teacher and high school teacher, I'm looking at all the books and I said, I never read this stuff. I said, I don't even know where I would start with things like Moby Dick and all those. I said, they've got to be onerous. They're long and it's not the current, what's his name? Patterson,
Yeah, James Patterson.
All these James Patterson, all these quick books. So I go to the shelf and here, I don't know anything about old literature. And I say, it was the best of times. It was the worst of times. I got this book in my hand. I'm picking up like an orator. I open up the book. The first phrase of the first chapter, it was the best of times. It was the worst of times. That's the only thing I know. Tale of Two Cities. I had no clue, what that was. So it just makes me think, though. It's like, here, Greg, and I know you've always been so honest with us as the host and listeners. You've always been so honest. And that's why I have you keep coming back on the program, that the best of times, I don't know what the hell that meant, but I'm going to make it my own phrase. The best of times, we've never seen anything like it, but it's not changing a penny it might even change attitudes, and maybe I haven't had it, but maybe someone will slap you on the back if they see a big news story. My brothers might say, hey, I saw that. That's pretty cool. The Wall Street Journal, this and that, but it doesn't change a penny. That's, unfortunately, that's what we all need. And so that's the worst of times. That's a sad part about it.
Yeah. And I love the analogy. And I think you just hit the nail on the head, right? And listen, I'm trying to think of a good way to say this, but we're at the beginning. We're not at the end. And, certainly there's nothing on the horizon in the next month, the next 2 months, the next 3 months that necessarily will materially, come. Now, hey, there could be some lame duck package. We'd love to see some portion of 9096 included in a lame duck package. At this point, unlikely, right? It hasn't gone through the committee process. Some of the other pieces of legislation have. But I think from my perspective, pharmacy needs to be past the hollow victories. Now, that doesn't mean you don't enjoy moments, right? And you've got to, and I tell my kids that too, right? No finish lines to things, and you have to enjoy the small victories and you have to savor those things. But here's the thing. I am not interested in seeing community pharmacy pass, some piece of legislation that doesn't tangibly change things and doesn't rein in practices. And hollow victories, right? So to your point, yes, it's an amazing time, and that there's people know what PBMs are, and by God, they know that they're manipulating drug prices to the detriment of patients, pharmacies, taxpayers, employers, name it. But the solutions that are being proposed at the federal level, by and large, are barely a Band-Aid. And that's not to say we're not grateful for the attention, because the truth is, these representatives, these senators, they could be introducing legislation about anything: banking, farming, aerospace engineering, and they're taking the time to try to rein in PBM practices. What's important is we have to fight the right fights. And you talk about being honest. One of my sort of, when you get philosophical, I remember in 2017 when I was in Georgia and Georgia Pharmacy Association, and we passed the first in the nation pharmacy patient protection. And up to that point, states had passed some audit laws, some licensing laws, maybe a little MAC pricing. But this bill came in and it said, hey, PBM, you can't do A, B, C, D, E, F, and G. And man, it felt good, right? It felt good. And I remember the magazine, we worked on it. It went out and it said something like Georgia tames the beast. And everybody thought, hey, we won. And of course, lo and behold, we did, right? There were massive enforcement issues which remain throughout the country. And so there's no finish line to this fight. But it's also important to have some context. And the truth is, when you look at it, pharmacy has scored some really, really significant victories because, and I say this a lot, hopefully I haven't said this to you before, but it's hard to pass a bill anywhere. And pharmacy has proven capable to pass bills in state after state after state. There's work to do on enforcement, but there have been victories, right? There are states now in Medicaid, whether it's a carve out or whether it's through an enhanced dispensing fee, where states are paying pharmacies fair dispensing fee, right? Fair being relative, but something in line with whatever the state Medicaid fee for service is. Hey, that's keeping some stores in business in heavy Medicaid managed care areas, right? So the advocacy paid off there. You've seen Kentucky had just a killer year this year. And by the way, the work that Kentucky, the independent group and the state association, the work that they did on that bill is inspiring. And you know what? They're doing it again on HR 9096. They have done amazing work advocating for that bill. And so it's important to remember that pharmacy has made great strides when you look at what laws are on the books at the state level in 2014, and then you fast forward to 2024. Great strides, still massive work to do. And at the federal level, we can all remember going up to DC and nobody knew what a PBM was. So we're in a different environment now, but tired of hollow victories, right? Let's fix this stuff. Let's cut off the legs that they stand on, to funnel billions of dollars into their coffers at the expense of patients, taxpayers, pharmacies.
One of the things that some of my guests, and we do this too as a pharmacy, a smaller pharmacy, independent, that, we can spin on a dime. We can care for the customer on a dime. We're not the Titanic and we can turn things around. Unfortunately, we can also go out of business on a dime. You talk to people that are like a month or two away from closing, some of them. And some of these bills, they're a lot of good news for some. I mean, sometimes things get broken up overnight, monopolies and stuff, but a lot of these things are good news for the auto industry because that means that in 2050 that this I'm going to be dead by then. So you hear this stuff and it just doesn't go as quick for us. Speaking about speed though, Greg. All right, so this perfect storm comes that we talked about, the New York Times and the what are the ones you mentioned? The New York Times, Wall Street Journal, the FTC, that kind of thing. Was this bill, which came because here's the thing, Greg, I felt bad because I had three of these guys on, Antonio and Benjamin and Luke on. I had them on to talk about the FTC new letter that came out. And I realized after the show was done, I'm like, oh, I turned this into a congressional thing because that news came out 4 days after the FTC did. And I'm like, I want Greg on here too if we're talking about congressional stuff. So the question is, how quickly was that by chance that the congressional bill was just sitting there ready to be, brought in? Or can't imagine it was built within that week after hearing that perfect storm of those things.
No, look, and you're right. I mean, this is a piece of legislation that had been worked on for some time. But sometimes the stars align.
Hearings and stuff, I mean, those are planned well in advance, unless you're having something like an assassination thing. But the other stuff is planned in advance. So this was 4-part perfect storm, basically, or more.
Yeah, that's right. That's right. And obviously, as we saw those things happening, the thought is, oh, wow, the timing couldn't be better.
Right.
But was it, planned to a T? No. What's the old saying? Better to be lucky than good, right?
Yeah, that's right. So this bill, I know that you played a part in it. How does that happen? Is it from your popularity and people knowing you're an honest, good fighter and things like that they call you up? How do you get involved with the federal bill? And now that I'm asking it, federal congressional people, they all represent a district. Maybe they pull people up from their district, but how does that come about then?
Yeah. So I'd like to say it was really based on looks.
I already told you that you and Antonio were going to be the bodyguards, and those guys are slick looking, man. I have a face for radio, so I'm not going to put you in that category.
But listen, right? We try to be, very policy-minded stakeholders, and we try to push out policy solutions and share research and be good stakeholders in that regard, and be looked at, frankly, as subject matter experts. And I think in a lot of ways, it's easy to look at community pharmacy and say, oh, hey, your Main Street businesses, maybe not the most sophisticated policy. But I think when you look at the history and the arc, again, independent pharmacy was out front on this before everybody else was. And, one of the things we've been saying is, independent pharmacy and Main Street sensibilities, but applied to policy. And I think independent pharmacy has that, right? We have got the solution that can fix these problems. And frankly, as complicated as it may feel when every time you look under a new rock, you see a new game, the solutions don't have to be that complicated. So we try to engage, we try to be good stakeholders throughout the country, at the state level, at the federal level. And one of the things I'd say, particularly about Congressman Auchincloss is he's very deliberate in engaging with different stakeholders with different views and really doing a deep dive into what is driving drug prices and what are the issues with vertical integration. Are there issues with vertical integration? And he's very deliberate in that regard. And so we ended up, really, I think, just developing a relationship based on, just discussions about, hey, what is going on in this industry? And of course, it evolved from there.
Do you think his first foray into that was his constituents, maybe a local pharmacist saying something? Because it's kind of a hard thing to take an interest in, because as soon as you talk to someone for like a half hour, your eyes are rolling back and you're like, never mind. I shouldn't have asked, So how does he go from learning about it to then wanting to do something about it?
He may be better to answer some of those questions, but certainly there are really engaged independent pharmacists in Massachusetts. And so that very well could have been, I'd also say, like, Congressman Carter's office has done an amazing job wanting to be bipartisan and, educate, different members of Congress on issues. And he had co-sponsored some legislation with Congressman Carter as well. But in terms of like the level of knowledge, and I don't know if I should share this or not, but the first conversation I ever had with him, I was taking my kids to Pigeon Forge, near Gatlinburg, Tennessee, about a 3-hour drive. And we were going to an indoor water park. And so, we ended up hitting traffic. And so we didn't get there in time. And I was planning on having a conversation with Congressman Auchincloss. So we get to within like eyesight of where we're staying after being in the car, probably anywhere from 3 to 4 hours. And the cell reception's spotty. And so I pull over and I say, hey, kids, don't worry. This will take, probably 10 minutes. Be quiet, don't say a word, no sneezing, no laughing.
Yeah, exactly.
You little punks, right? So listen, in DC, 99% of the time, you're talking with, anybody who goes up there, you're talking with staffers, right? It's very rare that you're having that conversation because, again, they're being pulled in a million different directions. Well, this is him, the first call, and it's Congressman Auchincloss, and we were on the phone for over an hour. And my kids the whole time are staring at the water park, and they have to sit still and they have to be quiet. And we're just having a discussion. It was eye-opening because the questions he was asking, Mike, were smart questions. And they were, critical. He was, scrutinizing these things closely and not with any preconceived notions. The questions he asks in hearings, he is one of the foremost subject matter experts on PBMs in Congress today.
I'm a big fan of question askers, because it's like to ask the right questions. That's where, well, even like with AI now, I mean, there's professions that are popping up of saying, well, we know AI is going to give us answers, but you got to put the right format in, the right questions of things. There's the people that are even learning how to do that well. Greg, I think I've been through the bill. Maybe I looked at a shortened version of it. How many pages is something like that? And how does that compare to bigger bills? The ones that nobody reads?
Yeah, so and it's really interesting, right? Because this bill is not the biggest bill, right? I mean, it's about 13 pages, maybe 12. And if you look at some of these other PBM bills out there, they may be 30 pages, 50 pages, 60 pages. And so, in a way, it's short and sweet for sure, right? But it gets to the point, and it's more comprehensive from a reining in problematic PBM practices than anything else that's out.
I mentioned my son, who's the English person. We always joke because you can always quote people and no one knows who the hell if they really said it or not. But we would say things like, I believe it was the great Mark Twain who said this, but it was someone like Mark Twain who said, have me do an hour speech, no problem. Make me give a 10-minute speech. And, that takes all kinds of planning. That bill, you can almost have a one-pager, tell the PBMs to stop screwing us, that kind of thing. But I know it has to have substance, but sometimes the shorter ones are like, hey, this is simple. This is 16 pages. We're not, that's the answer for us.
Yeah. And I think when you look at a lot of the bills out there, and it's like transparency reporting, and people are trying to be thorough. And so it's page after page after page of, you have to report this, but also this. And then you have to report this and this and this. And it can get so complicated. And what this bill really does in essence is say, hey, PBM, you can't do this, right? You can't manipulate drug prices. You can't steer patients. You can't force patients to get more expensive brand name drugs when there's cheaper generics. If you're going to negotiate discounts, here's a crazy concept. Stop charging patients fake prices, right? And it just says stop doing those things. And there you go, right? This is a movie that probably you've never heard of, but it always sticks to my mind in the policy world. It was a Disney movie. It was about the first seeing eye dog. And, the guy was a boxer, he got hit, goes blind, has the seeing eye dog. I think the name of the movie was Love Will Lead the Way, I think was the name of the movie. And the whole thing is this guy's trying to get this dog licensed somewhere in California. It's a novel thing. And years go by and he's fighting this fight. He becomes an advocate. And ultimately, I'm probably, messing it up. But ultimately, at the end of the movie, they say, okay, if your dog can get you through this obstacle course, then we're going to license him as the first seeing eye dog in the city or the state. And it's a tearjerker. And I still remember this because it was one of my older cousins that I was watching it with. And I idolized him. And I see there's like a tear running down his eyes. Like, oh my God. There was a point, just very rare.
Sure.
He's older, big, strong guy. But so it's a tearjerker movie because the dog is, it's arthritic. He's probably close to blind himself. He's old. And they set up this unbelievably elaborate, basically, obstacle course in a gym. And the dog looks at it for a minute and he takes the owner around the whole obstacle course. The dog was smart enough to know he couldn't take the owner through it. So he went around it, right? And we live in like the table that the PBM set. And it's so easy to play that whack-a-mole game. And
Absolutely.
to say, right, and to get caught up in every little detail and look here, but not here. And so I always think good policy cuts through all of the complications and all of the bull and just says, hey, don't do it, right? Or just get to the root of it, get to the heart. And I think that's what this bill does. I think that's why it's resonating as much as it is with independent pharmacy, but also, with patients as well. So,
Greg, what is the quickest way that something could change? For example, I always think that it's something like if our state said, starting tomorrow, these companies, I know they wouldn't do it, but starting tomorrow, this law says these companies have to be in Michigan or something like that. There's FTC things, there's congressional things, there's what else? laws, there's permits, there's contracts, there's all kinds of ways you can sort of push people in a certain direction. What would be the quickest thing? Like, what would be something that you said, okay, we got this, it takes so long, but what could be something that says, hey, we got this, and guess what? It's going to change next week.
I don't know that there's that one magic bullet, right? But what I would say is, the federal government is a massive payer, Mike, massive payer. When you look at, obviously, you've got Medicare Part D, you've got Medicare Advantage, you've got Medicaid managed care, which is 77% federal dollars. Don't quote me exactly on that. You've got a federal employee health benefit program, which I think is the largest self-funded program in the nation. And then you have TRICARE, and there's some others still, right? And so massive. And so if Congress were to act and enact, in total or provisions that are in 9096, again, there's not a long ramp up implementation period. This isn't something where there's reporting that's going to happen in 12 months or 24 months and 36 months. And hey, federal agencies go promulgate a book of regulation. It's PBMs, stop doing these things in federal plans. So, if Congress were to include that in some sort of a package or act on the legislation as standalone in, 2024, 2025, whenever that is, that would go a long way to stopping that, right? We've seen states act comprehensively. Some of their provisions have been really effective. Some haven't. Obviously, when you get to the state level, there's all sorts of preemption arguments. And I think that the state regulators usually should have the upper hand in light of PCMA v. Rutledge, right? Which found cost regulations that aren't central to plan design. There's no preemption. But hey, listen, they're not going quietly into the good night on that, right? They're litigating those points. There's a split in the circuits. So, but the federal government comes in and takes sort of that sweeping action that just says, hey, no, right? They take the pen out of the hand. You're not going to be setting drug prices anymore. You've lost that privilege. And when you think about this, when you put it in context, ultimately PBMs are government contractors or subcontractors for these federal plans. And they're utilizing their position as a government contractor or subcontractor to, I would posit, essentially fix prices, right? And rig it so that it is not a free market. And so that, they can have variable pricing, they can manipulate the price, they can steer the most profitable drugs into their channels, they can target the sickest patients and fragment their care. And I think that enough has come out when you look at 3-axis studies, look at the MedPAC reports, OIG, Government Accountability Office, now the FTC, right? There is enough out there to say, PBMs, you have lost your privilege. You have lost the public trust when it comes to setting drug prices and leveraging vertical integration to steer patients into your channels. So you're not setting prices, you're not creating networks, and you're not steering. Enough is enough is enough.
Well, first of all, if you're paying somebody, if you don't want your kid to drive a car and you're paying for the car, you take his keys away. And that happens like right when it happens. So I imagine that payment thing could stop like tomorrow if somebody wanted to. We're no longer going to pay you for doing this. I imagine that's quicker than even if the FTC or something said no oligopolies of the PBMs. That does, that's powerful, but it doesn't stop a pain. People still are writing checks back and forth. So I imagine follow the money. Who's paying whom? You could stop that as early as tomorrow if you wanted to. They don't do that for various reasons. Even if they thought it was a great idea, they're going to give some time. But that's probably that's probably the answer to that question. Things will happen the soonest with that. Because if they're just breaking the law, that's not going to happen soon unless you say someone's going to jail tomorrow if they do this. So it's probably who's paying. That's probably the quickest way to do something.
Yeah, and the federal government is a massive payer.
That's right.
But unfortunately, I think it is going congressional action. So many of the really bad practices, and I don't want to be sweeping and too hard. So many of the really egregious practices of PBMs in federal plans, the road has been paved by the agencies that really should be watching and overseeing. The term that is a very real concept, regulatory capture, agency capture. And one of the things that the PBMs have done just a marvelous job of is leveraging their relationships with regulators and agencies and really in certain ways, getting them to regulate and open the door for really, really problematic practices. You got 1 minute for digression?
Absolutely. That's what we're all about.
So,
Greg, I don't digress on this show. You know that.
The year was 1903. No, I joke.
Yes.
But, so listen, Congress, and don't quote me verbatim on this, but
Sure.
Congress basically comes in, in the federal code in regard to Part D, and they essentially say, hey, beneficiaries are going to get the benefit of the negotiated price. Prescription drug plans are going to negotiate prices, and beneficiaries are going to get that benefit. I'm going to get the year wrong. I think it's somewhere between 2013 and 2015.
Sure.
CMS is promulgating a definition or updated definition of negotiated price. And what do they do in that definition? After stakeholder input, meaning prescription drug plans, insurance companies, PBMs, they come up with an exception. And the exception is essentially negotiated prices, all discounts, except those that can't be reasonably determined at the point of sale. Okay? CMS's definition of negotiated price. And lo and behold, what do you think happens, Mike? Year after year after year, DIR fees grow. And what happens is they go to pharmacies and they negotiate, and it's sick when you think of it. Essentially, they negotiate discounts with pharmacies in a way that they can say they couldn't be reasonably determined at the point of sale. And so they deprive the beneficiary, America's seniors, of the discounts that they've negotiated with pharmacies. Now, listen, pharmacy for years advocated, for DIR reform. And the story that independent pharmacy told us, hey, they're taking our money, right? They're taking the money that they paid us. And it's true. But what was also true is the independent pharmacies, unfortunately, were the patsies, because they were overpaying the pharmacies at the counter on purpose so that they could take it back later and deny those to the seniors. And same thing with drug manufacturer rebates, because that's also DIR. And so in a 2023 MedPAC report, they looked at DIR, and I think the year was for 2021, and they found about 12 billion pharmacy DIR and about 50 billion in drug manufacturer DIR. Right? So you're talking about, roughly $62 billion in discounts that they negotiated that they didn't pass to seniors, despite the congressional intent, right? And the whole thing that enabled that is the agencies. And so while, sometimes agencies, take positive actions too, and I'm not going to say that CMS, hasn't taken steps to try to rein in certain practices, but there is an issue at the federal level and in state departments, community health departments, et cetera. There are real issues of regulatory capture. And it's not malicious on the part of the agencies. They don't even know it, right? But they have paved the way. And so what I can tell you that I'm sure of is the agencies aren't going to save them.
Greg, break that one out for me. Tell me that more slowly, that about the DIR, the seniors are not getting the discounts there, and it's trying to keep that money away from the seniors. Slow that one down a little bit.
Sure. And what I would say is this. You have to start from the premise of congressional intent. And if you kind of just a plain reading of the U.S. Code, the beneficiary is supposed to get the benefits of the negotiated price, the discounts that are negotiated by prescription drug plans, a la their pharmacy managers. The beneficiary is going to be America's seniors. And so what they did is they leveraged that loophole, right? So again, all discounts except those that can't be reasonably determined at the point of sale. Conceptually, that's what the CMS reg did.
Now, at the point of sale, they're saying, well, we're not there. How are you going to stand there and you're going to bring a PBM in and talk with Mrs. Smith and the pharmacist and work out a deal? No, we can't do it there. Just do this and we'll do it later. Is that what you're talking about?
Yeah, that's right. So, but again, the patient gets the benefit of negotiated price, but negotiated price was defined by CMS to exclude discounts that can't be reasonably determined at the point of sale. I think CMS probably presumed good faith. If you read some of their public rulemaking comments, they'll basically admit, hey, this shocked the heck out of us. We didn't see it coming. But what the prescription drug plans and the PBMs did is they took that loophole and they negotiated incredibly complex reimbursement methodologies for pharmacies and rebate methodologies for drug manufacturers. And that enabled them to deprive beneficiaries of those negotiated discounts. And that's the crux of what they did. And here's where it gets, I think, just particularly gross. The PBMs and the prescription drug plans, they know really well that, medication adherence is very much tied to the price of a drug at the counter. And there's, replete data and studies that show, right, that the lower the cost, the better the adherence. And then, of course, the better the adherence, the better the outcomes. And so what PBMs did is they negotiated these incredibly complex reimbursement methodologies with pharmacies, tied them to patient outcomes, patient metrics. They deliberately drove the price for the patient up at the counter. So the seniors are paying more under the auspices of improving patient outcomes. It's sick stuff, but they did it to the tune of billions of dollars. And so what DIR is, ultimately direct and indirect remuneration, what DIR prescription drug plans and PBMs are reporting back to CMS are those discounts that weren't reasonably calculated at the point of sale, discounts that the patient didn't get the benefit.
All right, Greg, when I have Antonio on, we're talking about all the different, he's saying that, I think he was quoting you. You guys just go in circles with each other. I'm just, all right. So I think he was saying that you were saying on a certain day, there was 80 different prices for the same drug at the same pharmacies, this or that, something like that. So let me see if I have this. So because that's so complicated, if the PBMs just said, the pharmacies, and you and I have talked about this, about index pricing. If the PBMs just said, all right, here's your discount, we're going to give you the index price, period. That's a negotiated price. And then the pharmacies would say, oh, that's easy. And anybody looking in would say, oh, that's easy. So then DIRs go away because it's so easy. That's the price right there. Because it's so complicated, it would take you an unknown amount of time to figure out what the actual price would be, kind of like trying to figure out a price from your wholesaler of what it's going to cost. But they're saying that the PBM says, look, there's negotiations, but we don't know how much is this going to cost. We don't know if they did the star ratings. We don't know what wholesaler, this or that. We don't know any of this stuff. How can we give the pharmacist that price right at that time? We've got to have computers run all this stuff. And then 3 or 4 months later, we'll figure it out. And then we'll figure out what the payment's going to be. Do I have that right? That's what the confusion means. That's where they try to confuse it.
Yeah. And, I'm going to give you one of my favorite quotes from Antonio, and it's where there's mystery, there's margin.
Absolutely.
Right. And that's what DIR fees was all about. And again, from a pharmacy perspective, it was horrible. Right? It's impossible to run a business. You're getting paid one thing, they're taking it back later. But when you step back and you understand, what the intent of Congress was, and you understand the import of the CMS regulation, the pharmacies were the patsy. It was all about denying the beneficiaries the benefit of those discounts, right? But that's why you have so much variability. If you move to an index-based model, you're aligning the price. You're having one price point for a drug. What you were alluding to, and it was a study that 3Axis did, and they looked at, Mike, correct me, I think it was like Deluxetine or something like that. I'm probably mispronouncing it. But they looked at same pharmacy, same PBM, same day, same drug. And there were 5 price points that day, ranging from like $9.30, I think, to $90, right? $9 to $96. And this is the same PBM setting the price for that drug at the same pharmacy in the same day. It's astounding. And why that variability? And think about it. If you're in Part D and, before CMS's updated reg, they're jacking that price up at the counter because they can take that on the back end. They're creating a spread on the back end. If you take that same drug and you're in a Medicaid managed care state where you allow spread pricing, that same pharmacy is going to be reimbursed rock bottom because they're going to create the spread then by charging, the state or the employer or the payer much more money. And so if you're in Medicaid managed care, you're charging the state more, reimbursing the pharmacy low. If you're in Medicare Part D, same drug, you're reimbursing the pharmacy high, so you can create that spread after the fact.
You guys are too smart for me. Let me slow this down still. So if it was simpler the beneficiary would get the discount right then. So in other words, instead of them paying $100 for something, they might pay $70 for something at the point of sale. So far, so good or not?
Yes. Yeah. They're whatever their cost share is, whatever their copay is going to be based on the actual price that the pharmacy is getting reimbursed.
Because they're paying a percentage of that? Is that right?
Could be, right. They could be paying a cost share. They could be in their deductible phase.
So if the price was lower, they would pay lower at the counter. Now, because it's so confusing, the PBMs can say, well, we can't negotiate that. It's too confusing at the point of sale. We'll do it later. But it seems like somebody would say, okay, do it later. And then at that point, let's say the old person, instead of them paying 70, they paid 100. Wouldn't they say then, all right, it's confusing now. We're going to do the math later, and we're going to mail that person back $30 to make it 70. I would think that they would send it back to the old person, but why don't they?
They don't.
Because it's smoke and mirrors on
They
that.
don't.
When it gets that far, it's smoke and mirrors.
Yeah, that's right. And because CMS paved the way, right? CMS had paved the way by allowing them to deprive beneficiaries of the discounts if they can't be reasonably calculated at the point of sale.
Does it go on further and say you can't do it at the point of sale, but later we'll give you the discount? Does that carry on?
It doesn't. It should. It should.
They just say, if we can't figure it out at the point of sale, you're not going to get it.
Some of it goes back to CMS. PBMs get to keep a lot.
They don't even pretend it's going to go back to the elderly. They just say, we're not going to give it then. We'll figure it out on the back end, but they're not going to get their money.
They're not getting their money. And so, you've got a scenario where, again, they're paying cost shares and deductibles based on gross pricing, not net pricing of the rebates. And they're not even getting the benefit of the pharmacy discount. So again, the CMS has updated the rule with regard to pharmacies and discounts, right?
I can see that on a percentage basis. And I know I asked this, but if it's not percentage, it could be tiered copays, something like that. If the drug's more expensive, you're going to pay a higher copay. Somehow they're not getting the discount.
Yeah. And think about this, just to make it worse, all the time you see this, Mike, I'm sure, right? Brand mandates, right? There's a cheaper generic available. The patient's in their deductible phase. They get, forced to get a brand that costs a couple $100 more. The PBM pays nothing. In that scenario, the patient walks in, the senior walks in. They think, my God, I've got insurance. It's saving me money. They slap down that insurance card. Pharmacy tries to fill it. Dow 9, right? DAW 9 code, brand mandate. Patient forks out a couple extra $100, covers the drug with their deductible amount. PBM doesn't come out of pocket a dime, but then they get a rebate from the drug manufacturer that they didn't share with the patient, right? That they didn't share with the patient, and they're getting paid for that. And we've seen, rebates as high as, 50% on some of these brand name drugs. So they're not coming out of pocket. They're forcing the patient to come out of pocket a couple $100 more, and then they're getting the money from the rebate. And then, pre the DIR fix, what was happening is they'd also take some of that money back from the pharmacy. So the patient, the senior, is putting money into the insurer and PBM's pocket. Their insurance has cost them money, and they're paying more than the pharmacies reimbursed, and they're getting a brand when there's a cheaper generic. And 9096 looks to remove those warped incentives and move to a system where the PBM isn't setting the price of the drug. The drug price is aligned for the patient, for the pharmacy, for the taxpayers, right? There's no brand mandates, and the patient gets the benefit of drug maker discounts.
Greg, about 5 years ago, 10 years ago, I don't know how long ago, I said, to hell with all this star rating stuff and calling the doctors for 10 minutes to do the PBM's work and things like that. Sometimes I said to my team at the store, I was like, maybe we're getting screwed in things because we don't do that. We're like so far to the bottom of the star. We're like in the center of the earth. Was that valuable for pharmacies that did all that baloney? Did they get a lot back? DIR, was it taken from me and given to them, or did they feel that wasn't worth it either?
I don't know that I can answer it. Look, certainly, pharmacies that jumped through the hoops got, maybe we're a little better off, depending, right? And that whole thing is so complicated too. But here's the thing. They were all hoops to jump through to create a show, right? It was never about taking care of the patient for the prescription drug plans. It was about denying the patient the benefit of those discounts.
It's like, we'll prove to you how we couldn't do it, how complicated it is. We'll set up all this baloney star stuff to prove that we couldn't have given it to the patient up front. Greg, I was at the pharmacy the other day, and one of my guys comes up and he says, good news and bad news. He said, this one company that they've never paid us a dime, but it was a card and they're taking DIR back. They've never paid us a dime because the copays have been so high for the patient. I said, well, that sucks. He said, here's the other part though. We just got a check for $30,000. Now, mind you, we haven't done brand name for 3 years. We just got a check from $30,000 from one of the big PBMs. And I'm like, well, they're going to take it back as a cash it before they can put a stop to the check. So we get this $30,000 check. We email, they give us some gobbledygook positively about getting it. No details, of course. And I told my guy, I said, isn't that a pisser? Isn't that sad? We had no idea this was due to us. You know, we wouldn't have known if we got it or didn't get it. And secondly, we did the same damn work, whether we got that 30 grand or not. And now we have it. Now, I'm not ripping the check up. I'm not that sad about it, but that's one of the saddest $30,000 I've ever gotten.
Yeah, it's sort of poignant the way you put it, right? I mean, it's just indicative of just how broken it all is, right?
Greg, I sent this guy at my store, I sent him this article in one of the, was it one of the Michigan magazines or something? And one of the Congress persons was saying how good PBMs are. I said to my guy, I said, check out his donors on there. He's just on the other side of the store. He emails me back about 3 minutes later. He says, yeah, $1,000 from so-and-so. You know, such a dirty, dirty thing. But it brings up the bigger question. Has all this gotten bad by the PBMs greasing the hands and filling the pockets of politicians? Is that why this thing's so damn dirty?
What I would say is this. I think that they have brought layers and layers and layers of complexity to drug pricing, and very deliberately, and they're able to leverage that. And keep in mind, look, this is what we do. This is the world that we live. If you're, you know, in a state house or you're up in U.S. Congress, the number of issues that you deal with on a given day, right? If you don't have a healthcare background, my God, you know, forget it. And so they've been able to, for years and years and years, sort of operate in those shadows and, you know, give out platitudes and, you know, show up and look like they're, you know, contributing to whatever the case may be, right? Lowering costs or whatever it is that they're appearing to do. And keep in mind, all of their savings, their quote purported savings, are off of, right, you know, list prices and gross prices and all that stuff that they've had a hand in inflating. But so I don't think that it got to be this way, you know, with, you know, backroom bribes, so to speak, right? But I think that these are amongst the biggest companies on earth, and they have brought layers of complexity at, again, and I think quite deliberate in working agencies at the state and federal level in a manner that the agencies are carrying their water and they don't even know it.
I'm kind of fascinated sometimes why different cultures might believe different things. And frankly, it's where they were born. You know, if someone's born in this part of the world, they're this persuasion or faith, and someone else is brought up here, they're that faith. And it's like, what are the odds of all these people being all born in the same part of the world where their faith is correct? It's just showing it's like where you were brought up. But PBMs, it's the same way. I mean, these PBMs have just flooded these people and everybody from day one. It's hard for people to break out of that culture when they were figuratively brought up in it with PBMs saving everybody money. It's hard to break out of that orbit.
Plato's parable of the cave, right? They've got all of us looking at the shadows.
Yeah, right. I just learned that last week for the first time, actually, that Plato's cave thing.
Oh, really? Was it when you were at the on the vacation with the old books? Or?
No, it was on YouTube. I wasn't reading the old books. Come on, Greg.
I was like, did you bust out Plato while you're on vacation?
No.
That's impressive.
But you know, Plato was his nickname. Did you know that?
I think I did know that.
It's some other name that I didn't know, but it maybe rung a bell. I forget what Plato meant, but that was his nickname. Greg, we need to do a little plug. And you didn't tell me to do this. We need to talk a little bit about APCI, American Pharmacy Cooperative, Inc. That's who pays you.
That's correct.
Who are they? What do they do? How do they benefit pharmacists?
Yeah. So they're based out of Birmingham, and they're member-owned, so owned by independent pharmacy. We're owned by independent pharmacies. I'd say between 1,600 and 1,700 independent pharmacies, so independent pharmacy-owned. And, the core function of, buying group is to, negotiate favorable...
It's a buying group, basically.
Yeah. Favorable,
Gotcha.
Drug prices from wholesalers, right?
Yes.
But, what APCI has done, I think quite deliberately, really focus on advocacy for years and years and years. And so I got to know APCI in my capacity as general counsel and government affairs at Georgia Pharmacy Association. And so we picked some really, really big fights, when I was there, and, introduced a lot of first in the nation things. Again, Pharmacy Patient Protection Act, first steering law in 2019, really strong in 2020, and worked really closely with APCI, and they were super, super supportive when frankly others weren't, right? Sometimes this is really forward-looking legislation. It doesn't look like legislation in the past. And, they were always like, let's go. We completely support that. And so ended up working really closely with them, for many years in my capacity at Georgia Pharmacy Association. And then, when I had the opportunity to say, hey, let's take this fight and make it bigger, obviously jumped at the opportunity to do that. And again, we had worked very closely in Georgia. But we're in over 30 states, and obviously we're not active in every single state from an advocacy perspective, but we try to be really supportive, whether it's policy solutions, whether it's drafting legislation, any way that we can help in the advocacy fight. We certainly do that. And then of course we're more involved at the federal level now than ever have been, and glad to be there fighting that fight.
So this is part of your job description. In other words, you've got a job there too. I imagine as a cooperative, you're doing a lot of contracts with buying groups, with different wholesalers, and anything that a buying group would need an attorney for. But you're doing this. I always see you in this other stuff. For me, it's like people see me in the podcast doing this, but they don't know that I also sit on my ass at the pharmacy, So
yeah.
I do both. In your mind, like, what is your split? And do the leaders, I guess all of the co-owners, do they tell you what your split should be? It's not like a hobby, this national stuff. How much do you figure you split between this and that?
It's not a hobby, right? But certainly a passion is what I would say. But, the general counsel we're in 30 states, big company. And so, there's a lot of legal work that gets done for sure, right? On the contracting side and other things, and nothing in healthcare is simple, right? From a, regulatory compliance perspective. So, spend significant time, with the general counsel hat on, quite deliberate in dedicating time to the advocacy. But in terms of a split, tough to say, right?
Would you say that I'm not very good on buying groups, knowledge of them? Would you say, are there other groups your size and some haven't even made a nod to something like this? Would you say APCI is a leader in this as far as having somebody as visible as you doing this?
I certainly like to think that we're leaders, and pursuing aggressive legislation and regulatory solutions. So yes, right. If there's a place for us to engage, we definitely want to engage, and we're always looking to evolve and move forward and advance pharmacy advocacy.
Are other co-ops as involved nationally as you guys are?
I would say it depends on the buying group, and each buying group probably looks at advocacy a little bit differently. There are some buying groups that really aren't involved in advocacy, and then there are others that support advocacy efforts through, likely financial contributions and assistance. But there are also other buying groups that do have advocacy teams, and there are some that have, really good world-class advocacy teams as well. But from an APCI perspective, and speaking for APCI, proud of the work that we do and think that we are advancing smart policy and looking to really shape the landscape in a way that's favorable for community pharmacies and for their patients. And again, proud of the work that we're doing in that regard.
Yeah, and these aren't the days of old where you've got to go to Washington for everything you want to do. I mean, you can sit at your keyboard and shout out to the world.
I'm getting to the age now, Mike, where you can also get hurt sitting at your keyboard. I was a couple weeks ago sitting perfectly still at my keyboard, staring at my screen, and somehow pulled a muscle. It's not without risks. These, sitting behind a keyboard, I guess is my point. Upper back and into the neck. And so, but literally, I literally wasn't moving. And so don't think it doesn't take guts to sit behind a keyboard all day, all right? It is not without risk.
I was just on Amazon last week. At home, I've got one of these wands, that you do you can give yourself a back massage. At work, I'm like, I need one of those things here because, I just sit there. Sometimes I'm tense on the computer keyboard or maybe just a certain position. So I said, I'm going to buy one of these for the pharmacy. And then I thought, you know what? I got a whole crap load of massagers in our cupboard when the kids, they'd buy you one or you'd get, when you got to buy something for the man who has everything, what the hell they're going to get me? I've got enough socks and, I don't wear ties. That's what I mean by everything. So I bring one of these big, they look like something from like Gilligan's Island, like this big life jacket thing goes around your neck like a horseshoe and it's a massager,
God. I'll buy it off you. Name your price.
Greg, one thing I like to sometimes look at I know your history and stuff, but I like to look at the LinkedIn feed sometimes before the show just to see what people are pissing and moaning about. But I see on yours, like in the last day or two, it said you want bill co-sponsors. What does that mean for co-sponsors? And what else do you want? How else do you want people involved? Do numbers help?
Yeah, look, numbers absolutely help. And, Congressman Auchincloss has worked this bill in a really inspiring manner, right? Because so many folks will introduce a bill and that's about it. But he has been really advocating for this passionately. And one of the things that he's asked for is for community pharmacists to really rise up and help him get co-sponsors for this piece of legislation. I think as of today, we're sitting at 14 or 15 co-sponsors. Which is a really strong start. And again, like Chairman of Oversight, Representative Comer is one of the co-sponsors, which is just unbelievable. But, here we've got in Representative Harshbarger and Representative Auchincloss, we've got folks who are willing to go out on a limb and advance the aggressive piece of PBM legislation that we've seen at the federal level. And that's a big deal. And they're asking for help. And so we absolutely want pharmacists to reach out, call their U.S. representatives and ask them to co-sponsor the bill, share with them the difference it'll make for their patients and for their pharmacies. And also, if they're active on social media, to tag their U.S. representative and ask them to co-sponsor H.R. 9096. We've seen in the last week or two, we've seen 3 co-sponsors directly from independent pharmacy visits, where the independent pharmacists took the time to meet in August when they were at recess with their U.S. representative, and it is translated into, literal co-sponsors within a day, which is just an amazing thing to see. And there are folks who are working really, really hard on this. I know, I know you were on the PBMs on the Rocks with Jeremy. But one of the things I'd say is Putt has just been an amazing champion for this bill. And their board and executive director have just been killing it. And some of the most sort of successful states have really just thrown themselves behind this too. Kentucky has been, I think I said it before, just absolutely inspiring the work that they're doing advocating for this bill. But we need all hands on deck. And pharmacists are busy and their heads are down and, it's a rough year. But this is the time for them to be heard. And so we are asking folks to call, write letters, email, and if you're active on social media, tag your U.S. rep and ask them to co-sponsor H.R. 9096, the Pharmacists Fight Back Act.
I never know if letters are going to get there. I think sometimes letters, they don't read them. Sometimes it's more like of a vote, like, hey, we got this many letters on this and that.
Yeah.
But I like that social thing of, hey, it's kind of fun to tag people and let them know that you're on that. The staff might get pinged or something on that. Does that help, do you think?
Social media, man, I mean, and I don't know if you remember, but Representative Auchincloss in that House oversight hearing, he was throwing out some drug pricing and he had one that was like a 38,000% mark. And so that video went viral on his Twitter and there's over 7 million views of that. 7 million, which is just a ton. It was shared over 30,000 times. And so just, really just went, for me, right? If I get 9 likes, Mike, I'm happy, right? I'm like, oh my God, this is fantastic. I love, wow. So amazing stuff. And so it is getting traction online, and it's a great way to do it, right? Tag, and you're creating and share and just.
Well, by definition, social, I wasn't even thinking about that. I was thinking about tagging them and they'll read they got tagged. I forgot about the whole damn thing about social, that these things can spread then. So what a great way to get involved on that.
Yeah, and it has, right? I mean, again, that was the hearing where he introduced the bill, and that thing, and it spread. There were patients sharing it. There were physicians sharing it. And so it was a really, really neat thing. And we want to, just keep that attention going, because that's what we need.
Greg, I'm thinking co-sponsor is just like someone stands up and then the next person stands up and yeah, we're with them. Is that what it is? It's just showing everybody's together, or is there something more to co-sponsoring?
Well, I mean, I think there's something more to it, right? Because again, they're taking their time to lend their name to a piece of legislation when there's thousands of pieces of legislation that they could lend their name to, right?
They're showing that it's important enough to do that.
It means something, right? And it's already getting attention, because let me tell you something. 50, 60, PBM pricing bills out there, they're working against HR 9096 probably the hardest right now, because it scares them and they see that it's getting attention, right? And so that's a big deal. But here's why it's important, Mike. Forever, we have not seen aggressive PBM reform legislation at the federal level because folks didn't think there was an appetite for it, I suppose, right? What we want to show, and I think we've already shown it, but we want to keep showing that, not only is there an appetite for it, but there is a movement, there is a consensus. There are people across parties who are willing to take the time to sign their name and fight for aggressive PBM reform and putting a stop to these practices. And so it absolutely makes a difference. Congressman Auchincloss, I think, has said his ultimate goal, he would love to see 25 Ds and 25 Rs co-sponsor that legislation. So we've got a ways to go in that regard to a really strong start, and we want to keep that momentum going.
Yeah. Boy, anybody listening to this, if you're already on the phone listening to this, tag this podcast if you want to. Tag it.
Absolutely.
It's going to have Greg's delightful face on the front of it, and it's going to have something about PBM on or something. So just send that to them.
Absolutely.
All right, Greg, you've got a white paper coming up. And what is that? And we're going to put a link to that in the show notes. So anybody listening now, right when you're done, hop on the show notes and click that. What is that?
There was a fascinating OIG audit in the Federal Employee Health Benefit Plan, the U.S. Postal Workers, a couple months ago. And we did a white paper on that because there were some really important findings in that, particularly if you read between the lines, because what it found, pharmacy's been warning about these offshore rebate aggregators for years. And lo and behold, guess what? There's rebate dollars flowing through those aggregators, and they weren't being passed back to the client on a pass-through contract. And lo and behold, they're denying rebates and payments from drug manufacturers to PBM-owned pharmacies, and even pharmacy discounts via fees under the argument that, well, these are aggregate discounts, they're not drug specific. So really important findings there, right? But there's been plenty of studies about Part D, about Medicaid managed care. And one of the things at the oversight hearing and some other PBM facing documents that we've heard lately is, hey, independents are getting paid more. Hey, we're not steering. And we're not setting price, things like that. And so what we did is we looked at a large federal employee health plan. And again, federal employee health program is the largest self-funded employer in the nation. And so we looked at some publicly available pricing data through a pricing tool. And we look at it, an independent pharmacy in Kentucky. And that independent pharmacy in Kentucky closed its doors in August of this year. Despite the fact that Kentucky has just been one of the most successful states, here we are, and, help's on the way via the Kentucky state legislation, and we still have pharmacies closing its doors. And so we looked at the pricing, like astounding. And so here, atorvastatin, the independent pharmacy that closed, was being reimbursed $12.58. The highest chain payment, same day, same drug, same plan, $90. $90 to the highest paid chain, $12.58 to the independent pharmacy. We then looked at mail order pricing because, of course, what do the PBM execs say? Hey, listen, our mail order is a cost-saving solution. And lo and behold, what we found, and we looked at, I think, like 20 of the most commonly prescribed generics. And guess what? Mail order getting reimbursed more, right? So atorvastatin, again, the independent pharmacy, $12.58. Mail order pharmacy, $27. And again, that's pretty consistent, maybe not on every drug of the top 20, but really, really consistent pattern there. And then what we looked at is, well, what if the beneficiaries in this plan want to fill a, quote, specialty drug, right? An MS drug, and I'm saying that in quotes, but an MS drug, a low blood pressure, cancer drug. And lo and behold, we just ran a few handful of drugs that we know PBMs like to play games with. And the most stunning one for me was the teriflunomide. I don't know if I'm pronouncing that right. But so the NADAC on that drug is $16.20. The independent pharmacy couldn't fill it, right? The patient can't get a price at the independent pharmacy for that. Has to be filled at the PBM-owned pharmacy. NADAC, $16.20. PBM specialty pharmacy, $7,636. 47,000% markup, Mike. And, we are going to be pushing this report out. And, frankly, I think the hope is, even that it opens the eyes of some pharmacists and spurs them to action because, they know it's happening. But even for them, it can be anecdotal, right? You don't see what the chain's being reimbursed. You don't see what the specialty pharmacy's charging. And so this is eye-opening stuff, I think, for pharmacists. I think for patients. But my God, the hope is that this is going to help compel congressional action because you can't look at these things and think the status quo is okay. You can't look at these, think, oh, hey, no problems here, right? I mean, you've got massive markups. You've got independents that can't fill the higher margin drugs. You've got the independent being reimbursed less than the chains, and then even less than the mail order. And so, I think it's compelling. I think it's outrageous. And it's definitely something that we're hoping to have some really substantive conversations around.
Yeah, I think of plan sponsors too. Somebody who's listening to this that maybe has insurance for their employees and realize they might be paying their smiling broker for this, PBM,
Yep.
This whole side, they're paying them $7,000 for something that someone could buy for probably $30 cash, something like that.
Yeah, that's right. And listen, man, that's one fill, right? And there's multiple patients on these drugs and multiple times a year, right? That was for 30 tablets, right? So patients on that for 12 months. I mean, the math just gets just incredibly disturbing. And one of the things that we haven't talked about, but I'll touch on briefly, that HR 9096 does is by moving to an index-based price, it also caps that price, right? So it's gonna cut out the ability for a PBM not only to steer those drugs to their pharmacies, but to mark them up, 47,000%, 10,000%, 8,000%, 300%, right? It's going to stop their ability to do that.
I don't usually give marching orders to the listeners, but here's the marching orders to our listeners. Take this episode, tag somebody in it, send it on, keep it going, have them listen to what Greg's talking about here. Go to the white paper in the notes and send that out. Send it to a handful of people, tag them this and that. That's too good of information to let sit there. Well, golly, Greg, what a pleasure having you on. You're going to be coming back so many times. It's just kind of like, hey, Greg, we'll see you next time. You're a busy guy, Greg, as we know. I know our listeners appreciate it, you coming on, and thank you. We appreciate you.
Well, I appreciate so much the opportunity to be on. And again, you were one of the first people who was really doing deep dives talking about these things. So it really is always a pleasure, and always enjoy listening to your podcast as well. So thank you.
Thanks, Greg. We'll talk soon. You've been listening to the Business of Pharmacy podcast with me, your host, Mike Kelzer. Please subscribe for all future episodes.